I'm Jessica and I'll be doing the tap block. It's 11:28. There's my timestamp. I don't know which way is right. I have my patient here. For the tap block, we went over risks, benefits. It's not a surgical block. It helps with post-op pain. The patient's going to be getting a left hernia repair, so we're just going to do a unilateral volume block. We went over risks, which would be last, since it's a high volume block with a lot of local anesthetic, so we'll watch for that. We went over that, went over our informed consent sign. It's been documented. The great thing about this procedure is it can be done while the patient is asleep. So the patient's already back in the OR, let's say, then I do not have to pre-medicate just for this procedure. Sort of indications, the patient risks, you do like peritoneal puncture, liver hematoma as well, adding on to that last and seizure risk. For supplies, we'll have a sterile mask and cap. I have my 3-way stopcock. This, since like I said, this is a volume block, I'm using half bupivacaine. I have 40 cc's here, 10 in my 10 cc syringe and 30 in the other one, hooked to an 18 gauge 2E. So I have all our supplies sterile. I'll have our ChloraPrep, which I will clean the area. We'll look for our landmarks on our patient to start before I clean. And so you look for your iliac spine here in your crest, and then you have your 12th rib. You look for your lat muscle and your external oblique for landmarks. So I would ChloraPrep, sterilize the area, and let it dry, and get all my supplies set up. I have my ultrasound across from me at the appropriate depth. It's going to be a deeper block. I have it all set up. I already looked at the patient with my ultrasound. I'll keep my field sterile. In the real world, we would have, I would gel my probe, put a cover over or a tegaderm to make sure my probe is also sterile, and have it hanging somewhere where it can stay sterile while I prepped. And then I would get my sterile gloves on, mask. My patient has a sterile mask on. I do not need a nerve stimulator for this procedure. Yeah, so we'll begin. So to start, I would find which side of my probe I have needle, keeping the cord out. Like I said, we're gonna look at the iliac spine. I will have my probe horizontal, and I would look, I actually found it right away. You can see, hopefully you can, I don't know if you can. I'm looking for my external oblique, internal oblique, and my transverse abdominis. And I also would see subcu tissue. And on the lower bar on the screen, I hold my probe still, with my left hand. I can see peristalsis, my peritoneum. There's my border. So I'm gonna move a little more lateral. I want to be as posterior as I can to block the lateral cutaneous nerve that comes off. And this will help the patient, the unilateral nerve pain from the incision of the surgery. So once I find, I'm looking for the crow's beak of the transverse abdominis. So once I see it, I can see subcu. It's got a external oblique, and I can see my internal oblique and my crow's beak. So the whole point of this block, like I said before, was a volume block. I do not have a helper with me today. Normally I would have someone else injecting my local, but for today we won't. Like I said, it's a volume block. I diluted my 20 cc's of bupivacaine and 10 of saline. Is it on my landmark? A good technique for this block is hydrodissection. So I would use that to make sure I'm in the fascial layer. We want to go in the fascial layer between the transverse abdominis and the internal oblique. And I would know it's in the right place if by hydrodissecting I would do a little bit of volume. You'd want to start with saline since we don't want to waste our volume. So that's why you have your stopcock with 2 different with your saline and your bupivacaine. And if the fascial layer pushed down, I'd be too shallow, and if it pushed up, I'd be too deep, and I would have to pull back my needle just a little bit. So with this block, you're gonna do an in-plane approach and trying to keep the needle as perpendicularly so you can see the depth of the needle as you go in, and I'm gonna go medial to lateral here into the fascial layer. And once you're in, you would incrementally inject after aspirating to make sure you weren't in a vessel. And slowly give your volume up to your 30 cc's like I had said. And I would ask my helper to help me as I injected each, or aspirated before each 5 ml injection. And then once that is done, I would take my needle out, clean up the area. You could have used like a Decadron for longer acting meds as well, or Exparel also got approved for this block. And then you would assess the patient's sensation if they were awake. For this patient, they are intubated in the OR, and this block should help them post-op so they don't have as much nausea from opioids, or hopefully don't have to take as many opioids for the block. And then you would also watch for any other symptoms. We did not get blood when injecting, so hopefully we didn't see any last by now, but we can continue to monitor the patient. Hi, it's Jessica again. We're back with our same patient. We went over risk contraindications such as coagulopathy, infection at site, or patient refusal. The patient went ahead with it. We did our informed consent and everything. It's in the chart. We just did the TAP block, and now we're moving to the popliteal. Different risks with this is it's highly vascular. We got the artery, the popliteal artery we have to watch for. So you have to watch for symptoms of blast. The patient does not have any infection at the site. And yeah, not on any blood thinners. We'd also watch for hematoma as a risk. This block is used for surgeries of the ankle foot. You can do it for the Achilles tendon. Sometimes it can be used with the femoral block for a full block, surgical block of the lower leg. So that's where we're going. So normally I would have a helper to help me with my injection. This will be like a 20 ml. I use half bupivacaine again. Injection. Have my stopcock with my 10 and my 20 here, just in case we need a little more. I will have my 22 gauge, 5 centimeter B-bevel insulated needle. We will be using a nerve stimulator for this to ensure that we are close to the nerves that we want to get. So the goal of this is to block. We're going to block your sciatic nerve, hopefully right where apex is in before it splits into the common peroneal and the tibial nerve. We go this high to make sure we get both nerves well. I have my electrode here. We would put on the lower leg. We would look for, if we were close to the tibial nerve, inverted dorsiflexion if we were close with nerve stimulation, and if close to the common peroneal, we would see everted dorsal with this one, and then inverted plantar with tibial. And so I would have my helper for this. We would look for nerve stimulation and the twitch response to go right way around 0.5, 0.4 milliamps. If nerve stimulation and the twitch of the foot went away at 0.7, we would know we were too far away from the nerves. If we still had it at 0.2, we would know we were probably right on the nerve or very close and have to pull back the needle. So I'm going to begin with our ultrasound probe. We said this is simulation, but in real world we would have sterile gloves, sterile mask, sterile cap, sterile everything. I'm already prepped the patient's knee with our ChlorPrep. It's dry, just for the sake of time. I can get you a better view here. And it's ready to go. And I would have this. We would ultrasound, or we would put jelly on the probe, and then have the probe go under the knee so you didn't mess with your sterile field. And this would you'd all have help, and someone would drape it, probe cover, or Tegaderm to keep your probe sterile as well. So when you're looking, I like to find okay. I like to find, so let me get the depth right, which side is medial for me. And I like to start the popliteal crease here, but I can't really see my face. And so your landmark, I'm gonna have my patient straighten out his leg a little more. I'm gonna have it a little externally rotated. Externally, there you go. Just relax it. We'll start the crease. Here you can start to find your artery and vein. I have to go a little deeper. Let's see. And what you want to do is you'll start there. It's about 5 to 7 centimeters higher in the triangle, and maybe 1 centimeter lateral. Need more gel already. Oh, falls off. Okay. So there I have my artery and vein. You can see the one collapses, one pulses. I would go up just slightly. See if I can find my nerves. Usually a little more hypoechoic. Let's see. Okay, so you can kind of start to see a honeycomb. Looks like there's 2. I'll kind of go up a little to the right. And here, to confirm, I got my patient slowly dorsiflex and plantar flex. I kind of have my landmark here. So with that, I would take my needle that I had already prepped. I would have the nerve stimulator ready. So you can see it. And I would also have my assistant ready. So you would have it, you're gonna go through your biceps femoris and vastus lateralis muscle. The point of this one, and you wanna go lateral, so that way you inject the nerve before you get to the vein or artery to avoid that. So as you go in, you would look for the twitching in your needle. Once you got a positive confirmation that you're in the right area, getting the right twitch response, you would definitely not want to see anything other than the twitch response I told you before. And you would slowly, incrementally inject after aspirating 5 mils. So I would ask my assistant to inject 5 mils, and I'd watch for some spread once I got my twitches around 4 or 0.4 milliamps. Kind of pushing hard, sorry y'all. And then I'd aspirate again, inject 5 more mils, till probably about a total of 20 mils. And once that was done, I could remove the needle, clean off the area. You wouldn't really have gel everywhere because your probe would be covered. You could take off your nerve stimulator, and then you would assess for the block. I didn't bring it up before, but the patient probably would have given like 5 of Versed or some sedation to make them more comfortable. And then once this happened, hopefully they could still participate, and I would assess for loss of sensation and motor of the lower extremity, and that's how I would know that the patient was ready for a surgical procedure. I would document and chart both blocks I just did, make sure in the computer I would screenshot the ultrasound with the local anesthetic injection, put in the chart, and then follow up with my patient afterwards and make sure their pain was under control.